everybody. My name's Michael Fine. I'm a writer and community organizer, a family doctor, and a public health guy, and president and board chair of Primary Care for All Americans. Thanks for joining us as we move from admiring the problem to breaking the stranglehold and building this movement and building this healthcare system that's for people, not for profit, and that starts by providing primary care to everyone in every American neighborhood and community. Man, are we rocking now? We have people in 40 states. We've got now 8 different work groups involving more than 40 people who are helping us build this movement. We've got meetings going, a number of times a week, more different meetings than I like to count some days. Um, and uh, and we've got this process going that feels like we're really moving now. We've got a process for training organizers and facilitators. We're building a culture that listens, that doesn't use professional titles, but makes sure all voices are heard. We have conversations, as I was saying a minute ago, with, with all sorts of community and professional organizations from around the country. And I'm going to apologize in advance for my cough and my voice. It's springtime in the Northeast, and I have everybody's allergies. I hope I don't have everybody's allergies all by myself. I hope some of you get to share some, but only briefly. Anyway, we have a great social media team of volunteers, a great playbook writing team of volunteers. We've got volunteer editors and copywriters, video producers, and fundraisers, even a couple of volunteer trombone players and clarinetists. And one or two are actually with us tonight. And I look forward to the day when we can hear them play as well as work together on building this movement to provide primary care to everybody. Next time, I'm going to be looking forward to introducing our newest board member, Hannah Hamdi, an amazing epidemiologist and midwifery student at Yale who had a family emergency and couldn't be with us tonight. She's somebody you're really going to want to meet. Regardless, I want to thank you and thank Hannah for stepping up to help. We need everybody. Please volunteer to help if you haven't already. And please come back and bring others every single time. This is our second work group Zoom, where we'll work together and then take a few minutes to hear what everyone else is working on. But before I steal the show, it's my great pleasure to introduce our moderator for this evening, Donna Smalls, and to thank the Zoom Committee of Primary Care for All Americans, and thank who organized this Zoom, and thank all the work group facilitators who have really stepped up and are working together, and to thank the coordinators and the communicators and the logistics folks who are making all this happen, and to thank John Wright, Brian Kaiser, and Patty Armstrong, our ACE Zoom producers. Take it away, Donna.
Thank you. Hi, everyone. Thank you all for coming tonight. Being here makes you part of building this movement as we break the stranglehold to provide healthcare for people, not for profit, in every neighborhood and community. Primary care for all Americans. As Michael mentioned, we've heard you. Tonight, we are implementing our new policy on culture, tolerance, and respect as we work together to create a welcoming environment where everyone can contribute their unique talents and ideas equally. So no professional titles, please. And let's talk about the importance of being here together, engaged in this work, and the value of those ideas and commitments, which are what will build this movement at the end of the day. Tonight, we are here to roll up our sleeves and to get to work. Instead of a main speaker, we are going to go into the breakout groups, and you will get a chance to talk to each other, to the members of the steering committee, and to the board, or to gather with others within your own work group to focus on the task at hand. Are you guys ready to get to work? Groups will have around 30 minutes to talk and work together on specific roles or topics. Afterwards, we'll all come back here together so that we can hear from each other. You're not going to want to miss this. Before you make your selection, we have asked each team leader to share a quick description about what their group is working on, Patty, can you please introduce to us our team leaders and work groups?
Absolutely, Donna. Thanks so much. All right. So just to make sure that everyone knows where they can go or where they should go, we've asked each of these team leads to do a quick little description, their elevator pitch as it is, to pick a group to join. So we are going to start off with the Playbook and Resource Guide team. Margaret, are you there? Can you tell us a little bit about what your team is working on and what you hope to accomplish tonight?
Hi, everyone. I'm Margaret Grady. I'm leading the Resource Guide and Playbook working group. And the Playbook will provide a menu of options so that anyone, no matter what their experience, can find a way to help us achieve our goal. The only requirement to become a member of the work group is that you are interested. So please join us during the breakout to share what you know and learn about our plans. We've made quite a bit of progress and we can update you on that. And tonight we're going to be talking about narrative and doing some work to see if we can develop a transformative narrative that promotes the goals of primary care for all Americans.
Thank you so much, Margaret. Speaking of narrative, this is something that applies right over to our social media team. Fatima, are you there and able to give a little bit of information on the social media team?
Sure. Hi, I'm Fatima, and I will be leading the social media team. In this fast-paced lifestyle, visibility is viability. And we here, the social media team, invite you to join us. No social media experience required. We are here to work together and spread the message and ideology of this group.
Thank you so much. Now we do have 4 state work groups, and this is very exciting for us. 2 of them are already have met in our last meeting, but would, I'm sure, be happy to have more people join. First is Rhode Island State Work Group that Greg Fox is going to be leading today. Greg, are you there? Can you give us a little description of what's going on in the work group for Rhode Island?
Absolutely. So we had our first meeting about a month ago where we heard from Rhode Island Senator Pam Loria about some exciting workforce bills that she's helping to sponsor. I had the ability and the honor to testify for both of those bills last week. And so we're going to give you everybody an update on that. And we're going to be looking to figure out what kind of assets we have. And I'm hoping to leave this meeting today with 2 distinct goals to accomplish something to report at the next time we have these types of gatherings.
Wonderful. We also have a Mass State Work Group making some waves. Wayne, are you there?
Hi, good evening, everyone. We're trying to make waves. We have our legislation that we call Primary Care for You, or PC4AA, that was reported favorably out of committee and is in the Senate Ways and Means Committee. And we're in the 4th quarter, 3 months left in our legislative session. And so we've got lots to talk about and would love for you to join us to help us strategize and join the conversation.
Wonderful. We have 2 new groups, as I mentioned. One of them is going as far west as possible to the great state of California. Greg Mansour, can you tell us what's going on the West Coast?
Thank you, Patty. Yeah, we're working on the Hawaii, annex for us, but we're going to start with California here. So good to be with you all today. California, as Patty mentioned, is a brand new work group. What we're going to really focus on today is just having a chance to convene as a group for the first time, talk a little bit about what's interesting us in terms of the needs inside the state, and then really try to spend a little bit of time getting ourselves organized, focusing on some key roles and needs to really help move the group forward. So looking forward to working with them today.
Wonderful. And that new group is also being part of the launch with New York State Work Group with Gino. Gino, can you tell us a little bit what's going on in New York?
Well, we're going to hopefully begin to organize. It's our first time, and Greg sort of stole some of my thunder with what I had planned, but we plan on really organizing, getting to know each other, organizing the group, and really discussing some of the issues, the big issues in New York State with primary care, Medicaid, workforce, and try to just decide what direction we want to move in.
Wonderful. So lots of discussion and some great engagement, hopefully, which is another group that we have, our engagement group with Larry. Larry, are you there? Can you tell us a little bit about what you're going to talk through?
Sure enough. So the engagement group is responsible really for thinking through and planning how individuals can get involved with our movement, both at the local level, which would be like a zip code level, as well as at a state level, which we've just been talking about. So we'll have a fun time getting to know each other and talking about potential, what would success look like within our given service areas.
All right. Well, it sounds like you guys will have plenty to talk through. If you are new to this group and you're trying to figure out what is PC4AA all about, I'd really encourage you to check out the newcomers group with Alan Roth. Alan, can you talk a little bit about what your newcomers group will be discussing?
Sure. So I'm Alan Roth. I'm one of the board members, and I've been here since the inception. So any of you that have not joined our Zooms or are not familiar with the organization and want to hear about what we are and where we're at and where we want to go, I'd be happy to talk to you in a small group.
Wonderful. Thank you so much. We encourage you guys to turn your cameras on. We are building community, and that's really tough to do if you only see a name or just a picture. We want to see you as a person. We will have each leader record the session to collect the information you're able to discuss and then help it to move us all forward. So you guys ready? John is going to activate our workrooms. You may need to go into the more on the bottom of your screen and select your work group. If you're joining us on a phone, you may need to tap on your screen to see the options pop up. But if you need any additional help, John and I will be right here to assist you and getting you into the right place to get to work. So are we ready, John?
Rooms are open. Leaders are automatically populating as we speak. So they should be there to greet you.
So I know that you told us a little bit about yourself during the introductions, but could you repeat it if you wouldn't mind? And I'll tell you about myself again as well.
You only heard from 12 people. How come you can't remember?
So you're Alexandria, Virginia, though. I think I caught that.
Wow, that's very good. Yeah, sometimes I forget, but Alexandria, Virginia. Have you ever been to this part of the world?
I have. My best friend lived in Annandale for years, and
so close.
Worked in DC, and I used to love to visit Alexandria. It's a lovely.
Well, we had a very fortunate situation where I retired from 45 years of family medicine in Alexandria a couple of years ago, and have always been involved with Larry Bauer and the family medicine educational, mainly going to the national conferences and the Innovators Network. So I've been kind of listening in and got to know Michael Fine that way. And he was here 2 months ago, and I went with him to visit a couple of the groups, Families for America and the Primary Care Consortium.
The collaborative, yeah.
So I got to listen in and see, what he's trying to do. And then we had him work with some of the people in Alexandria that are been doing like our neighborhood health, which is a federally qualified community health center,
right,
and a couple other people. So I'm trying to figure out how to go from starting to understand what's going on to being able to actually create something here in Alexandria, which is 150,000 people. And that's why I was hoping you would hand me a playbook and I could just follow the directions.
So you're you're not the only person who's shown up at this meeting with that hope, but we're very close. I think that by the end of May, we will have something. And so I see someone else has joined us. It's like they're in a car. So when you're ready, can you introduce yourself?
Yes, ma'am. So my name is Victor Guajardo. Sorry, I'm driving from the park. And I am a risk manager, benefits consultant, former director of benefits at a university system. And I personally set up primary care plans between, the DPC and employers. And I'm part of a group called the Hacker Hive, which is how I found out about the primary care group here. So I just wanted to pitch in and do whatever I could do to help. I am a risk manager, benefits consultant. I get work all over 50 states. The majority of my book is in Texas, Virginia, North and South Carolina, Montana, Arizona, and New Mexico.
Okay.
And that's pretty much me.
Great. Well, my name's Margaret Grady. I came to know Dr. Fine because I worked for the Rhode Island Department of Health. I was the chief of the Office of Primary Care and Rural Health for the state of Rhode Island. I'd previously worked in Maine, and I now work in Connecticut. But I ran a telehealth resource center for the Northeast states, done oral health programs, whatever. But my passion really is access to care, and especially access to care for rural populations. Anyway, Dr. Fine asked me to head up this work group. We've made considerable progress. I was just telling Pat that some of our other members are in the state work groups, California, New York, and whatever. So they're not joining us tonight. We had a pretty good meeting last night. We need actually, Pat, are you willing to report out at the end of this meeting, take some notes?
Sure, be happy to.
Okay. So one of the things that we did last night was sort of get a little bit more organizational structure in terms of making sure that every meeting that we have a person who's responsible for communicating the results of meetings to others. I'm primarily do facilitation. But so last night we went through a draft outline that someone had put together and added a couple of sections to it. And one of the things that we talked about was whether or not we needed a section on key messages, and just in general for the entire group, how are we communicating our message? What is the kind of language that we're using? And what are the values and basically the values that we want to communicate that will help drive policy decisions? So I introduced this concept of narrative dominant, a narrative and narrative structures and how they drive policy decisions. And I decided that we would try to work on that tonight. But then, as I said, other members of the group got siphoned off into the state work group. But narrative is something that people are starting to talk about, especially in the health equity and social justice spaces. So, it's the idea that we have these stories that we tell ourselves about how things should work, and they primarily support the status quo, and they drive policy decisions. So some of the examples of what these narratives are they're primarily anti-government, pro-market. They emphasize individualism, And they also emphasize scarcity. And I think for those, Pat, I don't want to offend anybody, but to me, these are primarily Reagan era concepts that were introduced during the Reagan administration and have really taken hold in the United States. And I can give you a little example about how they just creep into conversation and can be just sort of not ignored, but just accepted without challenge. So this morning I was listening to a National Public Radio story on Morning Edition about the fact that there were people in New Mexico who had become infected with HIV at unlicensed medical spas where they were receiving what's called a vampire facial, where blood is it, the people, they get this microneedling process on their face for rejuvenation, and then blood is injected into them. And due to unsafe practices, the blood product was contaminated and people got infected. So they were interviewing a dermatologist, I think from Chicago, and she was talking or whatever about with this and blah, 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 blah. And at the end, she said, and ultimately, we're all responsible for our own safety. And that comment went right by the interviewer without challenge. And I'm thinking, what? I work for a public health department that regulates and license and, you know, creates standards to create safety for people. And yes, I have a responsibility to inquire and about the safety. I would never go to a med spa for first thing, but then, you know, to go to an unlicensed spa to not sort of inquire about that. I think we do have a responsibility. But she was able to say on national radio without challenge that it's the individual that is responsible for their own safety and not a collective responsibility that we exercise through government by paying taxes. So to me, was just like an unbelievable example of how these kinds of narratives drive policy decision-making and drive people's thinking and drives their acceptance of the status quo, that you can go to a unlicensed med spa, become infected with HIV, and it's your own fault because you didn't protect your own safety. So anyway, I'm wondering if this resonates with anybody, and if you have any other examples or have heard about this at all.
Yeah, definitely. I've heard about that case. I don't know if it was a few weeks ago. It probably got replayed on Morning Edition or whatever NPR broadcast was on at the time. But I recall reading or hearing about it, and I was like, wow, this is crazy that first of all that happened, right? But I think, you know, back to the personal responsibility, there's a lot of talk about plan design for individuals such that if people spend over, you know, let's say we build a narrow network, and if people go outside of the narrow network, let me see if I'm breaking up. Sorry, I've got bad reception. Is that better? Okay, so if people go, you know, outside of the narrow network, which encompasses very good doctors and hospitals, then they will be responsible, you know, for any additional costs, right? The concept of out of network, but you just reapply it to something called open access. And it's supposed to make the individual more responsible with their healthcare dollars. And I agree with that, right? But you also have like the intersection of somebody should be responsible for their medical spend, and then, you know, they should be able to go to the best of the best as well. And so back to your point of like, you know, people going and getting this done, it's like, where does the responsibility for the individual begin and the, you know, paternalism or maternalism of everybody else end, kind of thing?
So I want to respond to what you said, and then I want to try to go a level deeper. So one of the underlying assumptions of what you just said about the narrow network and going outside the network is that medical care is a consumer product and that we are shopping for healthcare. But the reality is that when you have a health crisis, you go to what gives you the most comfort or what you feel is going to be best for you. And at that point, you're not really likely to say, oh, is this in network? This is out of network. And the example is, of course, somebody in an ambulance that gets transported to an out of network hospital and, you know, all of that sort of stuff. So I mean, so do you see how that thinking about how our healthcare system should work, or that's the status quo, kind of gets wrapped into the structures of insurance and plans and all of that. But you know, we're talking up here, we're talking about the health care system and how it works. And one of the things that you do when you look at narrative is you go down a level and you ask the question, why do we provide health care to one another at all in the first place? Why do we do it? What is, you know, and that's one of the things that I when I sent out an email to my work group members today and said, I want you to think about that. And so I do, you know, why as humans and as a society, why do we provide healthcare to one another? What's your answer to that?
Mine is it's a societal responsibility to make sure that other members are able to function. So I do a lot of nonprofit work, dealing with, you know, high cost medications for people with, you know, hemophiliacs or cancer or whatever it is. And so, you know, the portion of my mind that turns on when I'm doing that kind of work is like, this is a societal responsibility to help us take care of, you know, the disadvantaged and the people that are suffering for these high costs, right? And then I have the other side of, you know, the mind is thinking from a health plan structure, right? Which is outside of that realm, is like, you know, how expensive is this to the plan and the other members, and the distribution of the shared costs of you know, these members for that other individual, right? And oftentimes, you know, these individuals don't have health plans that I'm, you know, that I do the nonprofit work for. But I think, hey, what would I be thinking if these were part of a health plan that I manage, right? And there are two different answers that I give myself. One is like the CFO answer, which is, you know, I as a CFO have to make sure that I'm getting the best care at the lowest cost. And the other part is like, well, if somebody, and I deal with MD Anderson here in Texas a lot, so I'll use them as an example. You know, if somebody wants to go to MD Anderson, they should be able to, but also MD Anderson, you know, pokes our eyes out at 3,000% above Medicare, right? So it's weighing those two different things. But back to the question, I believe it is a societal responsibility to take care of the disadvantaged, and those who are suffering from, you know, certain disease states. So that's my answer.
So Pat, you're a physician, but why do we provide health care to one another?
I'm going to come back to that, but first, for housekeeping, if you want me to report on this meeting, I need to know who iPad is. And
oh, sorry, my name is Victor Guajardo, and I'm so sorry. I got home a little late, and so I have to help take care of my daughter real quick. But I love this conversation.
No, that's okay. But Victor is a risk management expert. I was really nervous when you were talking to us and driving and everything else. So I'm glad you're home. I'm glad you're home safe. And how do you spell your last name?
It is Guajardo.
I wasn't even close. And what was the name of that group? The hackers? What kind of hackers are you?
Oh, healthcare hackers.
Okay. And if you don't mind me taking a little time here before you go see your daughter, what are you doing in Virginia? Because I'm in Virginia and I'd love to meet up with you in Virginia.
Oh yeah, so I live in San Antonio, but a lot of the groups that I'm being introduced to are school districts in Virginia, and so I'm helping them design health plans. So some of them are part of the Jefferson Health Plan, others are part of other consortiums, risk pools, and some of those risk pools are becoming unaffordable. So the school districts and other entities want to see, hey, how can I pretty much go self-funded outside of the risk pool and keep healthcare costs down. And so that's where I kind of come into play. So I'm this sort of as needed tool.
So have you been working with the Rosetta group? Is that sort of?
Yeah, so I know Dave Chase and the other
Okay.
Health Rosetta individuals. I'm not a part of Health Rosetta. It's a little too, because I do a lot of free work, quote unquote. I don't make a lot of money, so I can't afford that, the Health Rosetta yearly expense to call myself a Health Rosetta individual.
Have you done work with Clint Flanagan and Nextera?
I've heard of Nextera and Clint, but I've never done work with them.
Well, look him up. He's done a lot of work with his school system. And speaking about a narrative, Margaret, I was trying to think of what kind of narratives do we want to try to promote that would be beneficial. And he has a great 3-sentence, summary about how once he introduced direct primary care to his school system, because his kids go to the school and they were, facing, bankruptcy to try to take care of the teachers. He set up this direct primary care access to primary care for the school system, and they saved so much money compared to what they were spending that now the teachers no longer have to buy their own school supplies. They have extra money left over. And it was such a great story, 3 sentences about you got this terrible problem, you got this solution, and now the teachers have school supplies, that they don't have to buy out of their own pocket. It's like, well, what a great, visual image. And that's kind of what I was thinking we ought to be working on, is a couple of short stories like
Hello,
that.
everyone. This is John Wright, and this is your 10-minute warning.
Okay.
Oh, okay. Do you need to take care of your daughter, Victor?
Yeah, so I'm gonna go jump in and bathe her real quick, and things like she's only 15 months. But I'm gonna go take care. But I can give you all my phone number and email. This has been amazing. I wish I wouldn't have jumped in at such an awkward time.
Not at all. There's no wrong door. And it did, when you signed into the meeting or when you registered for the meeting, you gave your information, so we'll be able to get in touch with you, or no?
I don't know. So I really just get text messages whenever a meeting's starting. So I don't know how I originally signed up. But yeah,
Okay, we'll track you down.
Okay, Victor Guajardo, but Margaret, Dr. Pat, it was so good meeting you guys.
Okay.
Well, if you go back into the website, Victor, you can sort of look at some of the past meetings that are on tape and sort of catch up to what's been going on and that sort of thing.
I will do.
Welcome aboard.
Right. Thank you, everyone. Look forward to speaking with you. Bye.
Okay. So I was getting a little seasick there. But that was really very, very interesting.
So what is really the goal of this committee or work group?
So we have a document that we're working on, where what we want people to be able to do is to guide them to resources, so if they want to start a state work group, or not really, it's not really how to start a state group, but if they have a state work group, where do they find the information that they need, and what it should provide them some guidance for what to do. So it sort of starts with directing them to understand what the strategic opportunities are in the state. What is the state doing about Medicaid? Do they have Medicaid waivers? Are they doing any sort of, what's their primary care spend? Are they benchmarking primary care? Do they, also, what are the policies around workforce? It asks them, it will give them a template for what data to collect on primary care workforce so that they can create a picture for policymakers of what the problem is. And then it's going to give them some guidance also on how to find out who's doing what in the state. Do they have an Office of Healthcare Strategy like Connecticut does? Or do they have an insurance commissioner the way Rhode Island does? And who are those individuals and how they get to know? Who are the members of the, legislative committees that deal with healthcare and things like that? And then we're going to sort of try to guide them to some actions that they can take in order to do advocacy and policy, help support policy decision making around primary care for all.
Are you creating similar guides and templates for local communities?
That's the next step. So once we get this done, we're going to move on to how to start a resource guide for community groups, which I think is actually going to be quite challenging, having worked with community groups for a good part of my career in public health. I think, that's where you can get people. I think that's where a lot of education needs to take place, quite frankly.
Let me ask you this, because in all my years of practice, I had almost no interaction with the health department. They collect statistics over here somewhere, and that was kind of all I knew about them. They had, immunization clinics once in a while, for kids or for flu shots. But I would think anybody in public health would just salivate over hearing what this group is trying to do, because nothing, as far as I can tell, could improve public health better than creating this movement and getting more people involved in access to primary care. So are the public health agencies activities sort of our natural allies? And
I would say no. So, so public health departments do not really have any authority over medical practice. That is governed by the boards. So the medical boards, the board of dentistry, whatever. So public health departments license, they collect the fees and run the online system where you renew your license. All of that money, by the way, that the Department of Health collects during the licensing process doesn't go back to the Department of Health. It goes to the general fund generally to fund other things. So so they're don't have a lot of interaction with the delivery of healthcare services in that sense, other than facilities and the hospitals, long-term care, all of that sort of stuff, all that sort of regulatory stuff, labs, whatever they have authority over. But the delivery of care, no, I would say the one exception is the Office of Primary Care, which every state has one. It's funded by the federal government, and they were established to help support the establishment of federally qualified health centers. And so they are the one office that collects data on healthcare workforce, and their primary responsibility now that the federally qualified healthcare system is fairly mature, their primary responsibility is to do calculations that apply for health provider shortage areas, which allows people to get National Health Service Corps and stuff like that. So, I mean, and I think Dr. Fine can really probably talk to you about this quite eloquently. I mean, because I think so you know, so a lot of what public health departments do is community health. Okay, so they, despite, you know, there's the regulation, there's a monitoring, environmental health, whatever, but delivering community health programs, making sure that, you know, there's a school oral health program, making sure that there's a Heart Healthy Communities program, you know, and these are all programs that are funded by the CDC or other health resources and services agency. It's temporary funding, so about 80% of the budget of a healthcare department is grant-based temporary funding. Okay, and so people don't have a long-term, you know, they have a 5-year grant, they've got a job for 5 years, and then they got to figure out what to do next, and so they move on to the next popular program. So, and so when I was in Rhode Island, the successor to Dr. Fine created this Health Equity Institute. And my office, I was in a team with the minority health and, you know, developmental disabilities, and they moved those 2 offices into health equity and left me behind and put me in under a regulator. They did not see primary care as being essential to health equity in the model that they were promoting. And it was, I left at, you know, essentially I left.
Well, welcome back, everyone. We would love to hear what's going on from your different work groups, what you've either learned or what actions you decided to take. So let's go through and hear from everyone as we wrap up this evening. So first, let's go back to that playbook and resource guide team. Margaret, are you there? Can you give us a little update on the discussion?
So I asked Pat to be the reporter out. I don't know if he wants to do that or not.
Sure, I'll be happy to. I attended the Playbook and Resources Guide work group. Most of the work group was heading other work groups, so Margaret kind of had to carry the ball for us. We were joined by Victor, who's a healthcare hacker, and he explained how he tries to help direct primary care practices work with school systems around the country and other groups that are trying to control their healthcare costs and try to put all those pieces together, basically providing access to primary care to places that are running out of money so that they can afford to take care of their people and have money left over to buy school supplies and other things. It's kind of a small model of what Michael's been talking about on a national level. But he travels all around the country trying to put these little pieces together, sort of on a one-by-one basis, but doing it with sort of self-insured groups as opposed to a whole community. But it's a great model because it works, it saves money, people's health gets better, all the wonderful things happen. And it's just solving the problem from an economic point of view, but it's the same solution. Anyway, Margaret talked about this work group working on trying to create a series of documents that the rest of us can use in our work at the state level. First of all, sort of listing what resources are available in a state, who does what in the state, how healthcare decisions get made on a statewide, sort of educating those of us who want to work at a state level, sort of what some of the forces are, who the people are, how do you go about getting laws passed and getting things done at the state level, particularly putting some templates together about sort of what information you have to gather to be able to help your legislators put some plans together for workforce issues and other things that are done on a state level. And then the next thing will be getting some templates put together for how you can organize at the local community, kind of who's doing what's the role of the health department, what's the role of different people at the local level. So we have some guidelines to give people who want to do something but just don't know how to get started or how to what it is we're actually trying to do. So I thought that was a very, very ambitious work group, and I think the work group would welcome anybody who has an interest in creating these types of documents. And Margaret, maybe you could summarize what you meant about how the narrative structures drive the conversation and how stories really are what it takes. People have to hear stories to understand what we're talking about, and it's stories and examples that create policy decisions.
Sure, I want to be respectful of the time, but we did start to talk a little bit about narrative, and I posed the question that I think that we should all think about, and that is, why do we provide healthcare? What is it and what is your reason for wanting to provide care to other people? And if we can answer that basic question about our values, we can come up with arguments and reasons and advocate for providing primary care for all.
Driving that why is so important and is really part of the work that your team is helping to guide. And then the social media team is really going to use that to draw others in. So thank you guys for sharing that. And we'd love to hear from the social media team about what they are working on. Fatima?
Okay. So yeah, the social media team has a more clear plan now, what we want to do, the posts that we have in hand, the videos that we want to put out, especially in the next 8 days. The plan is very clear. We are just waiting on one rate limiting step. So we would need to reach out to Patty for some information. And yeah, once we have that in place, I think the next week is going to be extremely fruitful and productive for us.
Wonderful. Well, I look forward to talking to you guys soon about getting a few more things put into place so that we can reach out to people as we keep going and growing as a community together. So speaking of communities, I'm super pumped to hear about how our 4 different state work groups went. So the first one would be Rhode Island. Greg Fox, what did you guys talk about?
Excellent. Well, first we got to know each other a little bit. And so, I have a whole range of experience in healthcare and primary care, which was fantastic. And we were able to share a little bit about progress on some workforce legislation that was heard last week. And then we heard, from one of our members about some parallel work building up the nurse practitioner and PA kind of workforce to enhance the skill set and to create an improved quality of care. And we're just pride in providing primary care in Rhode Island. So our goal is going to be promoting some workforce issues as well as trying to I guess make it cool to be a primary care provider in Rhode Island.
I mean, nothing is cooler than having a primary care doctor named Dr. Fox. I will tell you that. So, unless, of course, your name is Wayne and you're from the state of Massachusetts. So, Wayne, would you mind telling us what's going on in the state of Massachusetts with PCP?
Well, that was just a brilliant segue and well done. So we had a good conversation about where things are at in Massachusetts and some of the folks the different stakeholders we've been connecting with and trying to connect with, and some well-connected people and so on. We ended with an interesting conversation that asking the question, if primary care were made free for everybody, sometimes when you make things free, people don't value them as much. I'm not sure primary care applies to that rule or not. But if you make primary care free, in other words, no copays, no deductibles, and people have access to primary care, some people worry that that would be subject to overuse. And I know this is not a discussion forum, but I'd be curious to hear at some point people's reaction to that worry or that wondering. I know I can see the wheels turning in Michael's head right now. I mean, rapidly, Michael. Am I right? Can you confirm that the wheels are turning? I'll take
Well,
that body
when
language
before
as
Michael
confirmation.
answer, let me give you some example. When there was an insurance company had an emergency room, zero copayment or $3 copayment, people were going to emergency room, not doctor's offices. Because there was a negligible payment, they can go anytime. Same thing, if you get primary care totally free, it is going to be abused no matter what you say. We had to have some lock and key to that.
I think it's a really
Well-
interesting example. I think one of the counter argument would be that you've just made our point, because shifting people back to primary care from the emergency department by making it free, knowing that primary care has the triple superpower of better health, increased equity, all at a lower cost, maybe that's exactly what we want to happen. I think that's part of what Michael was going to say.
And I
A
think,
but I
great
know we have
conversation between all of you guys, and something that we will definitely have to talk about in a future Zoom call. Thank you, Wayne, for that. And jumping over to the California State Work Group, how did you guys do in your very first meeting?
We had a small group, so but we had an excellent discussion. Spent with the small group, had a chance to really spend a little bit of time just getting to know each other and hearing about our journeys, just across the healthcare landscape and what led us here. We didn't spend as much time, commiserating the sad Lakers loss last night. So for those of you that are basketball fans, but that's heavy on my heart right now. Some of what we did talk about, though, that I think was more about just sort of the state of primary care in the U.S. and some of the challenges we're facing is, the announcement today from Walmart, basically abruptly shutting down 57 of their primary care clinics, that they spent a great deal of time and effort building up over the last few years, as well as even just some of the corresponding things, and then using that as an opportunity to pivot and talk about what we see as opportunities and areas of focus inside of California. We did run a little bit out of time, started with the conversation around what some of the financial challenges are with primary care here. But key next steps for us clearly as a new group is just to get the word out, get a little bit more participation here, and start to get some people in some of those cardinal roles that Michael talked about at the beginning of this session today.
Absolutely. I mean, getting started is part of the journey, right? And we are excited to have you guys launching, as well as New York State Work Group with Gino. What did you guys talk about?
well, like Greg, we spent a little time getting to know each other, and we come from different parts of the primary care world and the medical world. So it was really exciting to have people who have different views of the same system. And we really wanted to emphasize and concentrate on 2 points in New York State. One is how New Yorkers are using or not using primary care appropriately, and really the workforce shortage that's impacting how the citizens of the state are not able to access and use primary care and get to primary care because of the severe shortage. So, and we really want to collect a lot of data, put it together, so we can sort of, when we go to state officials, we can show them data about how not only it's going to impact the care of the patient, but impact the whole system. And unfortunately, if we don't fix the system sooner or later will crash, because unfortunately, as more doctors retire from primary care and the aging occurs, the deficit between how many providers we have and the population, that chasm is just going to grow. And again, the system can only support it for a while. And if state providers don't realize, if politicians don't understand that, that's going to be a major problem going down the road. And in states where, like New York, where we're getting so many immigrants coming in, we don't have enough providers to care for the people that we have here. Now we have this influx. We need to make decisions quickly to try to adjust the system. So we're going to be mining data over the next 2 weeks. We've already exchanged emails. We're going to be sending information back and forth to one another. So in 2 weeks, we'll take our next step.
Wonderful. Yeah, there's a lot of work to be done just building this movement up, which is what Larry and Alan were both sort of working on in the engagement group. Larry, did you want to cover anything from the engagement group tonight? If you want to unmute, that would be very helpful.
You think that would help? So we had a good conversation. There was Michael, Jack, and I, and anytime we get together in a room, virtual or otherwise, it's always a whole lot of fun. So first of all, we decided maybe we should change the name of our work group from engagement, which most people don't, other than people getting engaged, they don't really know what that really means, particularly in terms of a social movement. So we were thinking of changing the name to Excitement and Fun Committee. And under that rubric, some ideas emerged. So there's been some conversation about parades in a small town, I believe in New Bedford, maybe, but somewhere up there in the reaches of New England, and organizing parades to gather attention and to have some fun. And it would be a way to get our musicians involved. We've got some musicians, and music is very important part of a social movement. Yeah, so we need to think about that. I didn't know this, but apparently there's a puzzle maker amongst our crowd. And we thought, wouldn't it be interesting to have a public puzzle contest? The puzzle of healthcare in America, and figure out some interesting way, to engage with people at local levels around that. Also, the idea was mentioned about sponsoring a salsa dance. As someone who is trying to learn salsa, I would welcome that. Good practice opportunities. We get some street dancers going.
That sounds all incredible. I think, Alan, will you come do salsa with me if we do a salsa dance class?
I failed that class, so that won't happen.
No, okay. You know what? I will keep trying, but maybe some of our other newcomers might be interested in the salsa dance class.
So SJ was in my group, and she is our puzzle maker, puzzle event person, puzzle app person, and I'm confident that she's going to work with Primary Care for All Americans to make us famous and put on an amazing event that's going to go national to everywhere. So we're very happy with her joining the newcomers group. And then we had two other newcomers, Corey, who's a family doc from Wisconsin, and Fred, a neurosurgeon from Rhode Island. I think both amazing additions to the organization. You know, Fred just highlighted so much how the system is so messed up from the specialist perspective, and, how they're in place to make hospital systems money. And Corey talked about, how dysfunctional the primary care system is, both in the Midwest and rural America, as well as working globally in New Zealand. So I think they both have a tremendous amount to offer our organization. I look forward to working with all three of you. So thank you.
Thank you so much, Alan. I really appreciate it. It's great to hear from all of these groups. We will continue to share out information from what's going on here. Keep checking your emails. I hope you're excited. I am. Donna?
Yeah, it's definitely really exciting to hear from everybody. And we encourage everyone to bring someone new to our next Zoom on May 14th. We will hear from Renee Citro, MD of Codman Health Center in Boston and president of STFM. She will be talking about how community health centers are instrumental in bringing primary care to all. Register on our website at www.primarycareforallamericans.org. And while you're there, click volunteer in the contact us section of the website to tell us how you'd like to be an active part of our movement. And please click donate to support our work group with a contribution. Really, every little bit does help. Once again, we need and appreciate every single one of you for helping us spread our movement across the nation so we can work together and get the change we need and that you deserve. Join us again in 2 weeks. Bring one person each time. Better yet, bring 3 or 4. Healthcare for people, not for profit, primary care for all Americans.
Please take a minute to complete our survey. This is a new model that we tried out again tonight. So we would like to hear back if it's working for you or things that we can continue to do better. The link is in the chat. We want to hear from you.
Thank you,
I
everybody.
just have one last question.
Yeah.
Do I understand from Larry Bauer that the work groups have now been transformed into play groups?
Absolutely.
I think that's great.
Call them that, yeah.
California
And
has changed its name to the Sex, Drugs, and Rock and Roll Group.
And Patty, if Alan Roth won't dance with you, I will dance with you.
Thank you, Larry.
Brian, I didn't think California had to change the name. I thought that's what California meant.
Thank you, everyone. We'll see you on May 14th.
Good night, all.
Thanks, everybody.